Alright, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon, ladies and gentlemen. Well, I really appreciate the kind introduction from Prof. Chong, and well, it's a great honor, particularly as I am more than most of the people here, to able to speak on the topic that I was given. And first of all, I'd like to thank the committee for making me part of this momentous event. Yeah, thank you so much. All right, so as you can see on the screen here, I was given a topic on the role of medical nutrition therapy in supporting treatment. All right, so my name is Betty. Okay, next. Okay, so these are my table of contents. There are a few topics that I would like to share about. So since I'm a dietitian, so as we go along this presentation, you will see a lot of food pictures. Yeah, why? Because dietitian and foods are, I think, best friends. Yeah, we are literally best friends, inseparable. All right. So let's talk first about malnutrition. Yeah, so this is a global issue. I'm sure everyone is aware of what is malnutrition about. But let me give a little bit on the definition. So malnutrition is actually deficiencies or excess in nutrient intake. And it is also the imbalance of essential nutrients or impaired nutrient utilization. Yeah. So malnutrition, it can be undernutrition, and it also can be overnutrition. Yeah, such as overweight and obesity. All right. So basically, malnutrition, it has been reported to be present in up to 20 to 70% among cancer patients. Yeah. And it also depends on the tumor entity, the stage of disease, and also the clinical settings. And the risk of malnutrition is definitely high, especially in those patients with head and neck cancer region. Yeah, for example, the NPC, nasopharyngeal cancer, tongue, buccal mucosa, and also many more, hypopharynx, laryngeal, and also not forgetting the upper gastrointestinal tract cancer, involving their cardio-esophageal junction, stomach adenocarcinoma, and also mid-esophageal, and etc. So this group of patients, actually, we can actually decide to assume that the risk of malnutrition will be there, and even without performing a screening test, because we can actually anticipate the malnutrition among these patients. Yeah? So, who is a dietitian? Who am I? Who are some of you who are dietitians? Yeah. So basically, dietitian, what we do is we assess. We can also diagnose, yeah, and treat dietary conditions using the medical nutrition therapy, or in short, we call it MNT. Yeah. So basically, what we do is we translate all the scientific informations into practical guidelines so that our patients are able to make their appropriate lifestyle changes, yeah, and also food choices to manage their disease. Right. So, medical nutrition therapy. So it is actually an evidence-based approach that translates scientific information on nutrition, health, and also diseases to enable individuals to make appropriate food choices to manage their conditions and also promote health. Yeah? All right. So we'll go to the nutrition care process. I'm sure this is very it is actually an important framework, yeah, for all dietitians and also nutrition professionals, because this framework is being used because it is a systematic method to for us to deliver, yeah, what we want to do for our patients, to make sure that we provide high quality nutrition care. Right? So it's actually composed of 4 important elements. Yeah, we'll start with the nutrition assessment. Yeah, assessment and the diagnosis, intervention, and lastly the monitoring and evaluation. And in short, we actually call it as ADIME or ADIME. Yeah. So these 4 elements is important and it need to be included in our care plan. Right? So I'll talk a bit about the nutrient assessment. So what do we do in the nutrient assessment? So we assess patients, yeah, in terms of their anthropometric measurements, yeah, such as weight, height, BMI, their weight changes, and body composition. If you have that body composition analyzer, and also their biochemical data, and their clinical features, and of course the dietary history. Yeah, so we get their diary calls to know that how much these patients are really eating at home. Yeah. How much energy, protein, fat that they are consuming, all right? And so once we have collected all this data from the assessment, we can actually start to diagnose patient. Yeah, we don't do the medical diagnosis definitely like the doctors, but we do the nutrition diagnosis. Have you heard of this nutrition diagnosis before? No? Okay, I'll give you an example. So nutrition diagnosis, actually it comprises of 3 elements. You need to have the problem and the etiology, what causes it, and also what are the evidence that causes all this issue through their signs and symptoms. I'll give you an example of nutrition diagnosis. Usually medical diagnosis sometimes will be shorter. For nutrition diagnosis, it will be a little bit longer. Yeah? For example, inadequate energy intake related to loss of appetite due to chemotherapy-induced nausea vomiting, as evidenced by their calorie intake of, let's say, 500 calories per day, or 30% of their energy requirement. So that is how we do the nutrition diagnosis. So with the nutrition diagnosis, then we can actually start to plan, yeah, the intervention, the appropriate intervention for our patient. Yeah? And after the intervention, we will definitely need to monitor and evaluate to make sure that whether these patients, are they making a progress, or they have actually achieved what we have planned for them. All right. So this is the framework, yeah, the nutrition care process. So if you look at the slide before, probably you think that it is a step that you need to follow, you know, accordingly. But sometimes it can be a cycle. Yeah. Sometimes we may need to go back and forth, you know, to redo back, to re-evaluate. So that's why it looks like in the cycle. Yeah. And the outer part here, the screening and referral system. Yeah. Because dietitians, if you need dietitian to see patients, so we need this referral from the doctors. Yeah. Most of the hospitals, the government hospitals or even private hospitals, doctors need to refer dietitian. Then only dietitian can see patients. But in IKN, the referral system is actually automatic. So dietitians need to see all inpatients in the ward. Yeah. So except for the outpatients, we will use the MST, the malnutrition screening tool. From that, then only doctors, then only we can know whether this patient requires dietitian referral or not. All right. Okay, so what are the goals of MNT? So there are 3 main goals. First of all, we need to address what are the current cancer and also treatment-related issues. Yeah. And secondly, we want to minimize the treatment-related side effects so that patients will not, they will be able, to eat, to consume adequate energy and protein. And also to anticipate and manage the acute, delayed, or even late occurring side effects of cancer. Some patients may go back after chemotherapy well, but then they may develop these late occurring side effects probably on the 3rd week, right before the next cycle of chemotherapy. So these kind of things we may need to also anticipate and manage with the oncologist. Yeah. So the goals must be individualized, definitely. So from the NCP, it's important that every patient receive individualized plan. Yeah, some may have similar disease, similar stage, but not necessarily similar plan. Some may differ slightly different. Yeah, because why? We need to know what is their nutrition status from the beginning of the treatment, whether they are healthy or are they already malnourished. Yeah. And also the type and stage of disease. Stage 1 and stage 4 definitely will not be the same, right? Okay, so probably there was some difference. And also their comorbid conditions. Are they diabetics? Do they have hypertension? Do they have chronic kidney disease? So all these we need to know, because we will also, besides providing MNT for cancer, we need to also manage their comorbid diseases and the overall medical treatment plan. But apart from all this, I also feel that it is important to also take into consideration the other points, such as their cultural beliefs, their social history, and are they doing well in their financial status, their family support. There are so many things they need to consider. So sometimes doctors may think, why are dietitians seeing this patient so long? So sometimes we see patients, especially new cases, we can see up to 45 to 1 hour per patient, because there are so many things that we need to assess and consider before giving out our plans, especially for the outpatients. But in patients, probably we can do faster, because why? We still have a few days, because when they are warded, we can see them daily in the ward, so we can routinely follow up them. Okay. So this is the nutrition goals during treatment, right? So if they are actually healthy and their nutrition status is good, so during treatment, we need to maintain their lean body mass and also their healthy weight. So how to know their lean body mass? There are several ways. One of the easiest one, through your measuring tape, and also if you have that body fat, body composition analyzer, it will be good to know the patient's muscle mass. And if they are malnourished due to their acute disease, so we need to consider all this. They will definitely have increased energy and protein requirements, so make sure our plan will have higher protein and higher calorie, to prevent them from having further weight loss and also muscle depletion, right? And if it's chronic disease related, so we also aim to maintain and also improve their lean body mass as much as we could. And if they are obese, we still need to maintain their lean body mass and may consider modest weight reduction. However, bear in mind, some obese patients, when they undergo treatment, they will tend to lose weight much faster than those who are normal or underweight. So that's why we do not really consider having this active weight management yet during treatment. We may consider that after they have completed all their treatments. So the methods of medical nutrition therapy, well, as early as possible, if we could, because it is definitely more effective when we start early. And it is an individualized approach, like I mentioned earlier, to oral, enteral, and also parenteral nutrition using evidence-based recommendation, guidelines, and also regulatory standards. And prompt and aggressive nutrition intervention is required for patients with pre-cachexia or cancer cachexia. So cancer cachexia is actually the wasting syndrome. Wasting syndrome related to anemia, weight loss, and also anorexia. So dietitians, we cannot only work with patients, we need to work with their caregivers and also the members of the healthcare team. The nurses especially, because when we provide plan, usually nurses are the ones that are very important to make sure that our plan will be done accordingly. Doctors, oncologists, MOs, pharmacies, physiotherapists, occupational therapists, and many more to name. Right? Okay, so management of nutrition impact symptoms, or in short, we call it as NIS. So this NIS is usually happen due to the cancer itself or the cancer treatments, right? Which impairs the oral intake, especially those, like I mentioned earlier, those head and neck cancer, upper gastrointestinal tract. So all these patients, when they undergo treatment, so these symptoms will definitely develop. The common ones like nausea, vomiting, diarrhea, oral mucositis, ulcer, dysphagia or odinophagia, pain in swallowing or difficulty in swallowing, early satiety. Sometimes early satiety may also happen to patients who have, for example, gynae, oncological patients, ovarian or even cervical patients, which already develop ascites. So early satiety is very common among them. And also extreme lethargy due to the treatment. Okay, so I will briefly explain 4 common NIS here. So we'll start with LOA, loss of appetite and also weight loss. What we usually recommend to patient is please eat food high in calories and protein. Small frequent meals will definitely help, and prioritize high protein food first while the appetite is best. Okay, and also try to encourage drinking milkshakes, smoothies and juices if they do not feel like eating solid food. And also nausea, vomiting, and there's a prospective study reported that patients who did not consume any meals before their chemotherapy were almost 7 times more likely to experience this nausea, vomiting compared to patients who actually eat before their treatment. So always encourage patients not to skip their meals, right? And some of the ways that we can also inform patients, eat blunt, easy to digest foods, dry foods such as crackers or toast, and also foods that are easy on stomach, less greasy, less fat foods, and avoid all these strong food orders. Usually room temperature food or drinks will be tolerated better. Alright, and sit up and try to sit up as long as they could, at least 30 minutes to 1 hour after eating, so that they can actually prevent from vomiting. Right? And also this difficulty swallowing, NIS, usually happens especially during the radiotherapy. So radiotherapy to the head and neck region, so they will have this difficulty swallowing, usually as early as the first week of the treatment. So what we can do is we recommend them to eat soft foods. If they could not, they will need to blend their food. Moisten their food with gravy and sauces, and may consider tube feeding until the end of treatment, or probably after a few weeks of the treatment. And the last one is altered taste. Some patients, they will experience increased taste sensitivity, especially to saltiness and also sweetness. And also those who feel the taste, metallic taste, bitterness. So these are very common. So these problems usually cause patients to lose interest in eating. So even those who are obese or overweight, they will definitely lose their weight very fast because they will have all these symptoms. Okay, so ONS, oral nutrient supplements, I'm sure everyone have heard about this. So this is actually a sterile liquid or in powdered form. So it actually contains all the macro and also micronutrients. And usually we recommend this if they cannot achieve the energy and protein through the diet alone. So there's a systematic review of multi-nutrient high protein or ONS found significant improvement in total energy and protein intake and reduced incidence of complications through ONS. So in IKN, ONS is very popular among patients. Their compliance rate is actually quite high because they rely on it as their total meal replacement. And there are many clinical benefits of ONS, include better weight maintenance, increased protein calorie intake, improved quality of life, and better anti-cancer treatment. So nutrition support, right? So for the use of enteral and parenteral in the oncology, usually indicated only if the oral nutrition strategy fails. Although it is not recommended as a standard treatment, but it may be beneficial for patients who are malnourished, and we expect them, they could not eat for a long period of time. So this is an example of a hospital meal. So in IKN, we actually provide a high calorie, high protein diet as our standard diet. So meaning we will have additional protein appetizer, probably like tofu soup, egg drop soup. Sometimes we also provide boiled chickpeas, red beans on top of the common protein here. Right? Okay, so these are some of the education materials that we also provide to patients, because usually verbal informations, they may not be able to remember all. So we have something for them to take home. And we have a few. These are one of the common ones. Protein and also nutrition care. To overcome the side effects of the treatments, like I mentioned just now. Alright. Okay, so we dietitians in ICAN, we believe that apart from providing good MNT, I think it's also important that we perform quality activities, yeah, such as clinical audits, innovation projects, and also research, right? So along the years, we have done a few clinical audits, and 3 of this, the first one we have done on malnutrition screening tool, and the subsequent ones we actually audit on the adherence of dietitians towards the nutritional support algorithm for head and neck cancer patients, right? And also last year we participated in the 13th Allied Health Scientific Conference. So we presented the study on comparison of pre and post oncology treatment weight in HNC cancer patients. Yeah, so everyone who have actually some time, yeah, if you think that research is tedious, yeah, I have a friend here, my good friend, my colleague. She has done numerous research while working, but I think you can always start with clinical audit first. Yeah, so it's a simpler one, but it can help to improve our patients' treatment outcome as well. All right. So with that, I thank you all for listening. Thank you.